Alaikum. Welcome back to my channel. In this video, I will share you the summary of Feigenbaum book, chapter number 11 of the Aortic Valve Disease. In this video, we will study the normal structure of the aortic valve. To understand the pathologies of aortic valve and the better diagnosis of its pathologies, this is very important to know the structure and physiology of the aortic valve. We will study Doppler assessment for the stenotic lesions, that how we quantify the aortic stenosis by the Dopplers, and also we will learn the modified Bernoulli equations to take mean gradients from the velocity as well as peak gradients. The real clip of the echocardiography is shown in the video, in which you see how we will work practically. So to understand properly, watch full video. The aortic valve is a complex durable structure composed of three equal cusps surrounded by a sinus of Valsalva, ensures unidirectional blood flow and prevents regurgitations. Structural components are three cusps: right coronary cusps, left coronary cusps, non-coronary cusps. Each cusp crescent shaped, supported by a fibrous annulus separated by the three commissaries. There we will see the right coronary cusps to the right side, to the RV side, the upper side. Look at I have labeled that RCC is the upper side, and left coronary side is the left side, and the non-coronicus is almost the uh, upper side of the interatrial septum, and this is the short axis aortic window. So all the cusps are shown here, and in the commissaries are, when it close the commissary is the end of the leaflets, you will see node of Arrhenius and cooptations. Pre-edges of each cusp curves upwards, forms the node of Arrhenius at midpoint. On closure, node meets in the center tight seal. Three line of closure radiate from the center in echo short axis view. Y-shaped closure line you will see. Okay, this is the 3D structure, 3D model of the aortic valve. And the midpoint you will see the dot shapes. This is the noodle of Arrhenius, already labeled here. Noodle of the Arrhenius. And in the echo, real echo, you will see the midpoints, taken points. This is the node of Arrhenius, and this is almost the Y-shaped of the Y-shaped in the echo short axis view. Almost this is the Y shape. Okay. Sinus of Valsalva is located behind each cusp, and the function is support to a cusp during systole and provide reservoirs for the coronary flow during diastole. So look at this place. The minimal is the dilated from the a little more space from the ascending aorta. There, this is called sinus of Valsalva, and this is also the reservoir for the coronary artery, as is reservoir the blood. which is uh, goes to the coronary artery and diastole. Coronary arteries and sinuses. Uh, left coronary artery. From the left sinus, the left coronary arteries goes, and the right sinus, right coronary artery. Non-coronary sinus has no artery arises. Position posterior and rightward near the atrial septum. The aortic sinus is in the pre-space. This is a 3D model though, so the pre-space behind the cusp is aortic stenosis. We have the aortic stenosis, and the coronary arteries. Look at the sinus of Valsalva. There we have also the coronary sinus, and the coronary arteries arise from the coronary sinuses of sinus of Valsalva. So the uh, left and right coronary arteries arises from the coronary sinuses. There is showing the diagram the coronary arteries arise from the coronary sinus. Okay, now sinotubular junction located at the posterior margin of the sinuses, narrowing of the aortic root, important to maintain valve geometry and functions. So as you see the diagram previous earlier, this is the sinus of Valsalva, this is the ascending aorta, and this is the junction, sinotubular junction, narrowing of the aorta. So in the center is a sinotubular junction, the Valsalva and the ascending aortic junctions. So this is the sinotubular junction you will see. Aortic valve disease can be congenitally or acquired, may result in stenotic regurgitants or both mixed lesion. The regurgitant and stenotic both are occur in the same times. Common causes of acquired disease like degenerations, senile calcifications, and the rheumatic heart disease and infective endocarditis like vegetations and so on. Aortic root and subaortic pathology also occurs. Aortic root disease can impair valve functions. Subaortic obstruction may also occur. Membranous subaortic stenosis and fibromuscular ridges and tunnels also impair the valve functions. Aortic valve mechanically precise and physiologically vital. Understanding the anatomy is a key for diagnosis the disease. We will study Doppler assessment of aortic stenosis. The assessment starts by determining maximal jet velocity through stenotic valve. We use simplified Bernoulli equations to estimate peak pressure gradients. This is validated in vitro and clinical laboratories, non-invasive and correlates with the invasive methods. It is widely used. A peak jet velocity accurate assessment requires recording the highest velocity through the stenotic orifice. Peak velocity usually in mid-systole. In severe AS there will be a rounded and dense shapes of the jet envelope. Late peaking jets are also seen in dynamic obstruction. Imaging views as an alignment. use multiple windows like apical 5 chambers, the suprasternal and the right parasternal windows. Critical to align, sometimes this is critical to align Doppler beam with the jet directions, and not non-parallel alignment underestimates the true velocity and the highest velocity. The color Doppler will guide you, and color Doppler improves alignment by showing jet directions. Careful probe manipulation and to optimize his signals. Our goal is to record the highest velocity from any window for accurate gradients. We use the Bernoulli equations. So the Bernoulli equation basic is the gradient is pressure gradient is equal to 4 v square. So the v is velocity in meter per seconds. The mean gradient from the tracing of velocity in envelope. The mean pressure gradients can also be estimated from the formula, and the formula is mean is equal to peak pressure gradients uh, into 1.45. So the two-third of the peak gradient is the mean gradient. So I will show you this in uh, practical echo. Okay, so this in this video you will see the uh, downward jet as a aortic stenosis jet. You will see the full envelope of the aortic stenosis jets, and the upper side is the aortic regurgitant jet. The aortic regurgitant jet is in the diastole phase, and the aortic stenosis jet in the systole phase occurs. So I will trace the whole envelope, and you will see what I get from this, from the start to the peak. And okay, we get the velocity 5.0, and the maximum peak gradient is 100 millimeter of mercury, and the main gradient is 68. So remember these values, I will show you in the calculators, that how the velocities. So we get the peak gradient from the velocity in the Bernoulli equations, and how to modify Bernoulli equation work to get the mean gradient from that velocity. So let's see the Bernoulli equation formula. We have 4 velocity square. So 4 in the formula is constant, and the velocity we have is 5.0. So first we square the velocity, the 5.0 multiply to the 5.0. So we get the 25, and then we multiply it into 4, which is constant in the Bernoulli equation formula. So we also get 100 millimeter of mercury peak pressure gradients, and we trace in the video also in the echo. So and that also the machine give us the 100 millimeter of mercury peak pressure gradient, and the modified Bernoulli equations work as for the mean gradient. So the peak gradient, as we get, we divide into 1.45. So this is also a 68, and you will see in the uh, video the main gradient we have the 68 also. So the modified Bernoulli equations and the modified Bernoulli equations is far better to trace full envelope. So you see how the Bernoulli equations can work. If we have only peak velocity, so and the peak velocity we should get and the main peak gradients and the main gradients also from the modified Bernoulli equations. The gradients reportings always reports both peak and mean gradients. The Doppler gradients may exceed kth values due to pressure recovery. If you know the pressure recovery phenomena, you will better understand. If you don't know and want to know, then comments. I will share you the pressure recovery phenomenon also. The Doppler measures peak at the vena contracta, the nervous points, and the kth measures from the downstream. So the kth values from the Doppler is will be low. So therefore we take mean gradients because the mean gradients is matched to the kth measurements, the kth values. So therefore we take the mean gradients. The pressure recovery occurs downstream from the vena contracta as the jet decelerate. At the vena contracta point, the jet is accelerate, so the pressure will be high, and the downstream the jets will be decelerate, so the pressure will be low from the peak. And the common this is common in small aortic roots less than 3 30 mm or 3.0 centimeters, domes, congenitals, AS, and prosthetic valves. The Doppler gradients is higher at vena contracta versus the cath lab gradients downstream. Sources of error is check Doppler recording. Check the Doppler recording quality when the discrepancies occurs. A poor signals underestimate the gradient. A misalignments with the flow causes underestimations and high severity greater impact from the poor alignment. Okay, the angle error impacts a small angle less than 20° cause minimal gradient errors. If we put the Doppler as minimal 20° of axis, so the gradient will be the less error in the gradients but small. If the angle will be large, so it cause major underestimations. Important in severe AS to maintain parallel alignments. Gradient types. Doppler mere peak pressure gradients and the cath lab reports peak to peak gradients, not simultaneous. The peak to peak values do not exist in times, so the mean gradients offer better agreement between the techniques. Physiological variability, if, the gradients vary with the heart rate, BP, preload, afterload, inotropies. And different if the different day test may yield different result. If the patients came the one day with high heart rate, so the pressures will be high. If the another day he will come, so the in low heart rate, so the pressure will be low. So that is vary the gradients with heart rate, BP, preload, afterload, ionotropy is also best agreement when Doppler and Cath perform simultaneous. Conclusions. The Doppler is practical and reliable for assessing AS. High jet velocity from any view must be used and understand limitation, pressure recovery, gradients type, and the variabilities. Good job. Quantify the aortic valve stenosis continuity equations. Continuity equations work as aortic valve area can be determined using the continuity equations. A stroke volume at LVOT is equal to stroke volume at aortic valve. Stroke volume is equal to cross section area multiply time velocity integral. So the aortic valve area is equal to the cross sectional area of alveoli multiply time velocity integral of alveoli divide by time velocity of aortic stenosis. The measurement we required to calculate the aortic valve area is the cross section of alveoli, time velocity integral of alveoli, and time velocity integral of aortic stenotic jet. Cross section area is equal to the formula is 0.785 multiply the radius square, where the r is the diameter of alveoli in centimeters. Measure from the parasternal long axis view, important to measure accurately due to the square radius effect. I will show you the real video clip in this part, this continuity questions. Sources of error in cross-section area measurements is poor image quality, annular calcifications, non-circular annulus, incorrect measurement levels. Underestimations is more common than overestimations. So Doppler measurement for ti- time velocity integral is time velocity integral ability is the pulse Doppler from apical window. Time velocity integral of A is jet. There is the continuous wave Doppler from the same window. And trace Doppler envelopes for accurate time velocity integrals. Validations and limitations validated and clinically in vitro laboratories correlate with Gaussian equations at low flow rates may overestimate the severity. Doppler simple positioning, simple volume placed in outflow tract, advance until velocity rises, then withdraw until laminar. Measure at these laminar points for accurate time. Advantages of continuity equations not affected by aortic regurgitations. If you have aortic regurgitations, the gradients will be high, and if more accurate in LV dysfunction with low gradients, if the LV is dysfunction, so the gradients will be low, and the continuity equations provide well area when gradients are misleading. This is the practical echocardiography real video clip. We see the in the continuity equation we measure the three things, which is first one is measuring of the LVOT area, radius of the LVOT. So this is the LVOT radius diameters. This is a 2.4 centimeters. Second is we measure trace the uh, LVOT VTI time velocity integral from the pulse wave Doppler. So this is 26.9. This is LVOT VTI is 26.9, and the third one is we trace or measure the aortic valve VTI. Here is the aortic valve VTI. We have 113.6 centimeter aortic valve VTI. So let's calculate the continuity equation aortic valve area of this that case. We have uh, a radius of 2.4, which is square. Then you multiply. So the radius square is 5.7, and the constant of the formula is 0.785, and then we multiply it to the time velocity integral of LVOT, LVOT. So the VTI of LVOT, in that case we have 26.9. This is 120, 1.6 almost. Then it will be divided by the aortic valve VTI. So the aortic valve VTI we have is 113.6. So we have the aortic valve area is 1.0 centimeter squares. So in this case we have the gradient, the peak gradient is 100 millimeter of mercury, but the aortic valve area is 1.0. This is also severe stenosis, but the gradient is so far high, because in that patients we have mixed lesions. Uh, we have the AR also, so the aortic regurgitations. Uh, we have the high gradients of the stenotic area. So for this purpose, the continuity equation is more reliable. And the severity of the aortic stenosis, we define that if you have gradient, mean gradient of less than 25 millimeter of mercury is mild, and 25 to 40 millimeter of mercury is moderate, and greater than 40 millimeter of mercury of the mean gradient is severe will be considered. And the aortic wall area is 1.6 to 3.0 is mild, less than 1.6 to 1.0, yeah, or 1.5 to 1.0 is moderate, and less than 1.0 is severe will be considered.